This is Complex Disease Management, Hour 3. We're going to cover from respiratory rate through daily monitoring tool today. We're going to start with how to measure somebody's respiratory rate, and you'll usually do this after you've taken their blood pressure and heart rate. You don't want to make them aware that you're taking their respiratory rate, because they'll change their rate and probably their rhythm of their respiratory rate. I'm sorry, of their respiration. So usually you'll take their blood pressure, then their heart rate, and you'll just want to usually just keep your fingers on their radial pulse, and instead of counting their heart rate anymore, just watch the rise and fall of their chest. And usually at least for 15 seconds, 30 seconds, and keep count of that, and you'll watch the rise and fall of their chest and count how many respirations they took. I'll talk to you in a minute another thing you're gonna make note of, but be aware that fever can add 4 breaths per minute per degree Fahrenheit above normal, and the reason for that is that's the body's way of getting rid of heat. That's how dogs get rid of excess heat too. They don't sweat; they have to pant to get rid of heat. So this is the body's way of trying to get rid of heat. So it's going to add you're going to breathe faster when you have fever. Normal respiratory rate is 12 to 20 breaths per minute. And the normal ratio of inhalation to exhalation is 1 to 2 or 1 to 3. What that means is for every breath in you take, it should take 2 to 3 times longer to exhale. You shouldn't have a 1-to-1 inspiration to expiration ratio. That's a sign of anxiety or shortness of breath. Now, they don't have to make that sound, but you don't want them to be breathing. And on the other hand, it's not normal to have a prolonged exhalation phase, because that is a sign of air trapping that people with COPD and emphysema have. They're having to force the air out because they don't have natural recoil. So it also is not normal for them to go. So that would be a 1 to 4 or 1 to 5, and could be longer than that. So you would want to make note of that. Bradypnea or bradynia, both pronunciations are correct. That is a respiratory rate of less than 12 breaths per minute, not 12 beats per minute like your handout says. It can be caused by head injury, hypothermia, side effects of some narcotics, which is a reason that people with respiratory problems, head injuries, can't have narcotics. Tachypnea is respiratory rate greater than 20 breaths per minute. Again, your handout says, your little booklet says 12 beats per minute, so you might want to correct that. It can be caused by exercise because you get short of breath. Atelectasis, which is collapse of the lung, and that is a collapse of part of the lung or all of one lung. Fever, like we talked about earlier. Reduced arterial blood oxygen content, and if you aren't getting enough blood, you have to breathe faster to bring the oxygen in. Metabolic acidosis. Let's see what I've made my little note about metabolic acidosis. I get to talking and yep. Metabolic acidosis is when the body fluids contain too much acid, and it's because either the body produces too much acid or the kidneys aren't removing the acid. Anxiety or pain can cause tachypnea. Oxygen saturation. It's an index of the actual amount of oxygen that's bound to hemoglobin, and it's expressed as a percent of the total capacity, or that's what we think, or that's what we want. But I did a little research, put together a little presentation within this training, and when I finish, you may think, well, why do we do oxygen saturations at all? But I just want you to be aware. Oh gosh, I'm sorry. What the heck? I just want you to be aware that the O2 sat meter is not the end all, be all monitor. We can't clip the oxygen sat meter on somebody and it read 92% and we say, oh, you're fine, let's keep going. And they're dripping sweat and they're telling you that they're exhausted and they're so short of breath. We have to take the readings just like blood pressure, just like any other measure we use. You have to consider the whole person. But I want to tell you about a little bit about pulse oximetry. The red and infrared light that's in a pulse oximeter pass through the skin and is absorbed by the sensor on the other side of the clip. Oximetry measures light absorption over a number of pulses, usually only 5 pulses. Then the data is passed through the computer that's in the little oximeter, and the computer collects the data from the 5 pulses and interprets it into understandable numerical values. There are factors that affect accurate oximetry. There has to be sufficient perfusion in the monitored area, and usually we clip it onto their finger. Some oximeters can be clipped onto the ear, some can be clipped onto the toe. So there has to be sufficient blood flow to the monitored area. If the patient has a weak or absent peripheral pulse, the pulse oximeter reading won't be good. So if they have bad circulation, to their hands, not going to get a good oximetry reading. Patients most at risk for low perfusional states, we're talking about low circulation rates, are those with hypotension, hypovolemia. Hypovolemia, we're talking about they have low blood volume. What would make them have low blood volume? If they're dehydrated, if they don't have enough liquid liquid makeup of their blood. If they need a transfusion, they'll be hypovolemic. And hypothermia, if their hands are cold. And those in cardiac arrest. And I almost didn't put that in there when I was looking online. I thought, well, who's going to take their O2 sats when they're in cardiac arrest? And I thought, I better be careful. I could just see somebody in cardiac arrest and somebody rushing in there with a O2 sat meter and wanting to take their O2 sats. Well, when your body is in a crisis, your body is in crisis mode and wants to preserve the essentials. It's going to try to save the brain, the heart, and the lungs. It is throwing the extremities to the wolves. It's trying to save the essentials. So throwing a sat meter on your finger is useless because the body automatically shuts down blood to the extremities and shunts it to the central body. So you're not going to get an accurate O2 sat reading if somebody is having a stroke or a cardiac arrest. People who are cold might have vasoconstriction in their fingers. That'll compromise arterial flow to their fingers. Cardiac arrhythmias can also cause inaccurate measurements. And I don't want to underemphasize this. So people who have, which almost all of our old people have a cardiac arrhythmia. That can cause very inaccurate measurements, because remember, it's taking a reading over 5 pulses. And so what if one of those pulses is missed? There's not a heartbeat during one of those 5 pulses. That can really mess up the O2 sat reading. If they have deeply pigmented skin, so somebody with very black skin can cause an inaccurate reading on the pulse oximeter reading. Jaundice or high bilirubin levels. A patient with hyperventilation who receives 100% oxygenation might have a normal level even though they're suffering from respiratory acidosis. Moving and dislodging the sensor, which can be caused from a rhythmic movement, such as tremors of Parkinson's, seizures, or even shivering, can lead to an inaccurate reading, because the sensor is trying to detect the beat, the heartbeat, and can't tell what's a beat and what's movement from what's a movement from a beat and what's a movement from shivering. Exercise and vibrations can make it difficult for the pulse oximeter to determine which is the pulsatile tissue. If the sensor is too loose or too tight, the readings can be altered significantly. Pulse oximeters can give a false high reading in the presence of carbon monoxide that's in cigarette smoke, and we know that. I don't know if you realized, which I maybe have knew at one time but forgot, carbon monoxide binds to hemoglobin 250 times more strongly than it does to oxygen. Hemoglobin would much rather bind to carbon monoxide than it would to oxygen. Once in place, it prevents the binding to oxygen. It also turns hemoglobin bright red, so the pulse oximeter is unable to distinguish between hemoglobin molecules that are saturated with oxygen versus those that are saturated with carbon monoxide. And these false high readings that are obtained from smokers are affected for up to 4 hours after smoking a cigarette. Up to 4 hours. External factors that can affect the accuracy of the reading include bright light that shines directly on the sensor, because the oximeter is measuring the amount of light that's transmitted through arterial blood. So if you have an external light that is interfering with the sensor's ability to distinguish, dark blood, the hemoglobin, or I'm sorry, sorry, I'm getting mixed up. Light can interfere with the infrared light's ability to see through the blood. Dirty sensors. What can get the sensor dirty? You all can just imagine. What's on our patients' fingers and under their fingernails. Dark colored nail polishes, dried blood can affect the accuracy of the readings by hindering or altering the light absorption of the contact probes. So like I said, you might be thinking, why in the heck do we use the O2 sat meters at all? Don't think that, but just be aware. When you look at that reading and you think, well, just a minute ago it said they had a 92%, and now it's saying 67. What could be causing that? Could be because they have oh gosh, my mind just went blank. It could be because they have irregular heart rate, and when you took it a minute ago, they had a regular run of their heart rate, and then when you took it the second time, they had a missed beat, an irregular heart rate, or that there is something clogging the sensor, or it could be any number of things, or they just had a cigarette 2.5 hours ago. There could be a lot of things that are interfering with giving you an accurate reading. So just be aware, and if there's signs, if what they're reporting just isn't matching up with what the O2 sat meter is saying, investigate further is all I'm saying about the sat meter. Okay. So normal O2 sat readings over 95%. Moderate insufficiency is above 90%, and abnormal O2 saturation is below 88%. Now, there are some cases where the doctor will tell you that lower levels are acceptable, just like with diabetics who have been diabetic for years and years and years, and their body accommodates to higher resting blood sugar levels. The same can happen with oxygen saturation levels. It does not happen very often, but if a doctor tells you that it's okay for this person's O2 sat levels to be at 84, at 86, then just document that and go with that. It's because their body chemistry has been that way so long that their tissues have adapted to that lower level of oxygen. But these are textbook normals and abnormals. Hypoxemia is defined as the failure of the respiratory system to adequately oxygenate arterial blood. Clinical complaints are shortness of breath, particularly with exercise. Other common clinical signs will be tachycardia, so a fast heart rate, tachypnea, fast respiratory rate, hypertension, cyanosis, so their lips, their tip of their nose, their fingers will be blue, and confusion. Dyspnea, want to emphasize that that's an individual's sensation of difficult, labored, or uncomfortable breathing. It's not a scientific value. It's not a number you can say, oh, this means this value, this number, this test means this person is dyspneic. It's a subjective complaint. Just know you want to document dyspneic SOA, shortness of air. You don't want to document SOB. It's just SOB, we all know what that means, and you don't want that in the medical record. Normal reasons for dyspnea: after vigorous work, after strenuous work, after running a mile. It's not normal to be dyspneic when they're sitting at rest, or after walking 10 feet, or after brushing their hair, or after shaving. That's not a normal reason for dyspnea. So that needs to be documented when they're dyspneic at rest, and all the signs that go along with it. If they're not making normal facial expressions at rest, or after mild exercise, or mild ADLs, or normal sounds, that needs to be documented. So abnormal reasons for dyspnea, we just talked about that. At rest with mild exercise or even moderate exercise, you shouldn't be dyspneic. And these can be associated with emphysema, chronic bronchitis, COPD, obesity, pulmonary congestion. How to measure dyspnea: the Ranchos Los Amigos dyspnea scale, perceived dyspnea scale, or a modified Borg, and the visual analog scale. We're going to go over these in a minute. The Ranchos Los Amigos dyspnea scale. 0, that scale goes from 0 to 4, and this scale was created by therapists at the Ranchos Los Amigos Rehab Hospital in California. And at 0, the patient is unaware of the need to breathe. It's just like right now, you're sitting there, you're listening to me babble on, you're not thinking about, well, I need to take a breath, well, I need to exhale, well, I need to take a breath, I need to exhale. It just happens. It's a passive activity. 1+ dyspnea, mild. The patient has a slight awareness of the need to breathe. The subject can hold a conversation without difficulty. Dyspnea is not noticeable to the observer. So I'll bring this up in a minute. 2+ dyspnea, there's some difficulty. The patient is definitely aware of the need to breathe. Dyspnea is noticeable to the observer. Rate and depth of breathing increases, and accessory muscles begin to function. The patient breathes in mid-sentence or shortens sentences in order to breathe. I would say, excuse me, I'm going to wipe my nose. Okay, I would say that I am having 1+ to 2+ dyspnea because of I get all excited and I get a little dyspneic because I get all jacked up and I'm nervous. So, and another thing about this scale is you can notice it has a patient report and it has an observer report. So if you look back at the scale again, the patient has a slight awareness of the need to breathe. The patient is definitely aware of the need to breathe, but then it also reports that the observer, that dyspnea is not dyspnea is not noticeable to the observer. Dyspnea is noticeable to the observer. The rate and depth of breathing increases. Accessory muscles begin to function. See, when I take that deep breath, you see my accessory muscles. So for me, I would report that I'm having 1+ to 2+ dyspnea, occasional dyspnea, and you can give your report of what you see with me. 3+ dyspnea, moderate difficulty. Breathing is rapid and deep. Accessory muscles are prominently functioning. Conversation is short and choppy. The patient must breathe after 3 to 4 words. How I remember that: 3+ dyspnea, must breathe after 3 words. 3+ dyspnea, 3 words. 3, 3, 3, 3, 3, 3. 3+ dyspnea, 3 words. Okay. 2+ dyspnea, have to cut sentences in half. 2, half. 2, half. Okay. I know I'm driving you crazy with this, but all these scales run together in your head, and you have to make some association to remember them. So 0 dyspnea, noticeable. You can't even notice anything. 1+ dyspnea, it's mild. You know, the observer doesn't even notice it. The patient has a mild awareness, a slight awareness of the need to breathe. 2+ dyspnea, the patient's definitely aware of the need to breathe. May need to cut the sentence in half. 3+ dyspnea, you can only say about 3 words. It's definitely noticeable to the observer. Prominent use of the accessory muscles of breathing. And then 4+ dyspnea, severe difficulty breathing. That's the top. That's the end of the scale. Severe difficulty breathing, can only say 1 word time. Conversation is difficult to elicit. They may have to nod yes or no to get communication across. That's the Ranchos Los Amigos dyspnea scale. Okay, the observer can rate and the patient can rate, and I'll tell you how you could use this scale in combination with something else in a minute. Then you've got the perceived dyspnea scale, from 0 to 10. How short of breath are you? On a scale from 0 to 10, 0, you're not short of breath at all. 10, you just can't hardly breathe. And your patient's going to give a scale. Now, I'll give an example of where you might want to use both of these scales to figure out where a patient's at, as well as for education. Let's say that your patient has been a couch potato because they had, I'll try not to be sarcastic. Let's say your patient had a heart attack. Let's say 2 years ago. I'll say 2 years ago, and is scared to death to do anything. And it was a very frightening experience. So has been basically becoming more and more deconditioned, sitting around her apartment. So right after the heart attack, she could do some for herself, prepare her meal, get dressed, and she's just gotten to where she can do hardly anything. Gets extremely short of breath with doing anything, and it's just gotten to the point she cannot care for herself anymore. So you have her perform an activity, making a sandwich, and so she's standing at the counter, and she's making her sandwich and gets anxious, and she thinks she's short of breath, and says, "Oh my gosh, I've got to sit down. I cannot. You're going to have to let me rest. I've got to rest for a minute. I just cannot do this. Oh my gosh, you got to let me sit down. I got to sit down right now. I can't. You got to let me sit down. I can't do this anymore. Oh gosh." Right. Now, you're going to say, "Mary, how short of breath are you? On a scale of 0 to 10, how short of breath are you?" "I'm a 10. I can't do this anymore. You got to let me sit down." Okay, she's rated herself a 10. Now, how we've described the Ranchos scale, remember we said that a 4 is severe difficulty. Conversation at this point is difficult to elicit. One-word answers or inability to speak is common. So, if she was really a 10, that should equate to a 4. But she's able to talk, so she is equating anxiety with severe shortness of breath. And really, I would give her maybe a 1+ to a 2+, maybe, as an observer, as an evaluator. I would give her a 1+ to a 2+. She's confusing anxiety with shortness of breath. Yeah, she got a little short of breath, but she jumped right into anxiety and is wanting to sit down. So maybe over the course of therapy, we can educate her about, okay, so of course we're going to let her sit down at first because this has to be a process. But we're going to educate her about, okay, I'm taking your heart rate. Your heart rate is this. Here's your blood pressure. You were standing fine. Your knees weren't buckling. And, next time we'll just stand here. We'll just stand here. We won't make your sandwich. Let's just stand here for a minute, and we'll just talk while you stand here. And you're doing fine. Your color looks good. You're not sweating. And talk her through it and help her learn what the physiological signs of anxiety are versus the physiological signs of respiratory distress, and help her close that gap so that she knows it's okay to get a little tired. It's okay for your legs to start, for you to feel the muscles contracting. It's okay for your back muscles to start feeling a little tired. And it's okay for you to take a deep breath. It doesn't mean you need to sit down. It just means maybe you can stand there and rest for a minute. Let your arms, rest your arms on the counter. And then once after about 10 seconds, then you can keep going again and help educate them about the physiological signs of rest and work and recovery, and so that they can work again. That it's okay to work. It's okay to feel a little tired. It's okay to get a little bit short of breath, and help them push their limits of exertion. And that's how you could use these two scales, I'm saying against themselves, or I should say in combination, to educate the patient and help them become more active and more active in their life again. The visual analog scale. I'm going to explain how it's supposed to be used, and you can decide whether you want to use it or not. It's probably best used in a research setting. The visual analog scale, how it's really, really supposed to be used. You've got this line. It's a 10-centimeter line. And on a given day, you say, Mary, on this line, at the bottom, you're not short of breath at all. At the top of the line, you're short of breath as you can imagine. Will you point on that line how short of breath you are? And they point. I'm this short of breath. Okay, then you get out your ruler, and it says 7.5 centimeters. So 7.5 over 10 is 75%. So they are 75% short of breath. And then next week you do your progress note, and they point to, they point to here. And you get out your measuring device, and it says 6.2. So 6.2 over 10 is 62%. So last week they were 75%. Today they're 62%. So they've had a 13% decrease in their report of shortness of breath. Now, if you want to use that scale, that is great. It is extremely objective as far as being able for Medicare seeing a numeric increase or decrease in their report, in their subjective report. That scale is most often used in research. If you want to use that scale, go for it. It's just kind of labor intensive, but it's a good scale. Now I think what did I want to do here? I wanted to do a little quiz, and this is going to be this video's affidavit or proof that you watched this video. So I want you to write down what is the normal resting heart range. So in your email to me, please just write down these answers. Normal resting heart range is, okay, what is too fast? What heart rate is too fast? I'm looking for a number. Over what? Over what number is too fast? Okay. Below what heart rate is too slow? Okay, what will the heart rate do during exercise if the patient is on a beta blocker? What will the heart rate do during exercise if the patient is on a beta blocker? That's a medication. Okay, I'm going to describe a patient scenario. And then I'm going to ask you what you would do in this situation.